Hi, my name is Monica Desai,
And my name is Rana Andari.
and we'll be presenting on the use of point-of-care ultrasound in the diagnosis of necrotizing fasciitis. We have no financial disclosures to share. So let's review necrotizing fasciitis. Necrotizing fasciitis is a severe, life-threatening soft tissue infection. It spreads quickly, so prompt diagnosis and surgical intervention are necessary. Without this, negative health outcomes such as limb amputation or death can occur. Currently, the gold standard for diagnosing necrotizing fasciitis is through surgical exploration, and advanced diagnostic imaging is used to aid in the diagnosis. CT scans are typically the gold standard for diagnostic imaging. So why are we looking for an alternative to CT? Well, CT scans expose the patient to excess radiation, are expensive, and take a long time to complete. This time manifests itself either as wait time as the patient waits for the CT to become unoccupied, or as time spent on the logistics of patient transportation and patient metrics. Point of care ultrasound, on the other hand, does not expose the patient to radiation, is cheaper than CT, and is a portable bedside diagnostic tool. This means that the machine can be taken to the patient's bedside, getting rid of wait times and logistical complications and decreasing the time to diagnosis and surgical intervention. So our objective with this study is to determine if point-of-care ultrasound can be used in an emergency department setting to accurately diagnose or aid in the diagnosis of necrotizing fasciitis. In order to diagnose necrotizing fasciitis from an ultrasound clip, our ultrasound fellowship trained physicians use the staff exam. Staff stands for subcutaneous thickening, air, and fascial fluid, which is what the physician looks for in the ultrasound of the infected area. So what does the staff exam look like in practice? Here you can see 3 ultrasounds, one of a normal soft tissue, one of cellulitis, and one of necrotizing fasciitis. As you can see, the normal soft tissue ultrasound has relatively uniform layers of tissue. The necrotizing fasciitis ultrasound clip differs from normal since there's subcutaneous thickening circled here in green on top and air bubbles in the middle circled in red. I've also included a cellulitis ultrasound as this is usually the diagnosis in our non-necrotizing enrollments. Cellulitis differs from both normal and necrotizing fasciitis due to its cobblestone appearance. This study was conducted at the University of California Irvine Medical Center Emergency Department. Undergraduate research associates screened for and consented patients who are over 18 years of age and English or Spanish speaking. They must also have had a soft tissue infection and have been receiving a CT scan or surgical consult as part of their care. Next, the emergency physician would take an ultrasound of the infected area. The ultrasound clip was then analyzed using the staff exam mentioned earlier by an ultrasound fellowship trained emergency physician who was blinded to the patient's final diagnosis. Finally, the ultrasound fellowship trained physician's conclusions were compared to the patient's final diagnosis determined either by CT or surgical exploration.
So in this study, we have 64 total enrollments. 6 of these enrollments were true necrotizing fasciitis cases that were diagnosed perioperatively. In these cases, 100% of their ultrasound clips confirmed necrotizing fasciitis. We also had 3 false positives, meaning necrotizing fasciitis was not diagnosed perioperatively. However, both the CT scan and the ultrasound interpreted it as necrotizing fasciitis. That leaves us with 58 non necrotizing cases that were diagnosed either through CT or surgery. And in these cases, all of the ultrasound clips were interpreted as non necrotizing. So, with that said, our results show 100% sensitivity or a 100% true positive rate of ultrasound when comparing it to the final diagnosis, and a 94.8% specificity or true negative rate of ultrasound as well. Some limitations of our study are that air can be a late finding in necrotizing fasciitis. This means that patients in early stages who have not yet developed air may be grouped into a non-necrotizing group when being screened with ultrasound. Also, participants were only recruited between 8 a.m. and 4 a.m., as that was the schedule of our undergraduate research associates. The sample was collected from a single site, as Monica mentioned earlier, from the UC Irvine Medical Center, and the sample size was relatively small. So for our conclusions, The preliminary data suggests that point of care ultrasound can be used to aid in the diagnosis of necrotizing fasciitis. The results thus far indicate a 94.8% specificity and 100% sensitivity in discerning necrotizing fasciitis from non necrotizing cases. The high sensitivity of point of care ultrasound contributes to its strength as a screening tool for necrotizing fasciitis. Thank you so much for listening, and we'll be here if you have any questions.
Hello, everyone. My name is Linda Q. I'm a resident at Rutgers, New Jersey Medical School. Today, I'm going to be presenting suboptimal documentation of emergency department point of care ultrasound scans and missed potential revenue. My team includes Dr. Rob Adrian, Dr. Anna Frischman, Dr. Meghana Hedney, Dr. Samantha Laris, and our attending Dr. Stephen Allerhand. I have no financial disclosures today. For our project, we wanted to see if we were following the ACEP guidelines for properly documenting and signing ED point of care ultrasound scans to ensure that they appear in our electronic medical record for clinical decision making. Some background on the topic: many emergency departments use EMRs and separate software to order and document point of care ultrasound scans to support billing for the ED. There have been a few studies to date that have looked at compliance with proper ultrasound documentation. We wanted to investigate our own large urban ED to see if we were adhering to point of care ultrasound documentation. And we also calculated the missed potential revenue as a result from poor documentation. The current standard in the ACEP policy statement for ultrasound basically states that ultrasound findings should be immediately interpreted and communicated in the EMR via some sort of written report to ensure timely interpretation of the scan and for proper patient management. This documentation should then result in some sort of appropriate reimbursement for the services provided. We looked at point of care ultrasound scans in our software called QPath performed within a 6-month period. We excluded any scans that were not assigned to a resident or attending, any scans performed by non-EM faculty, and any educational scans. The data we extracted included indication for the scan, so if it was a cardiac scan, biliary scan, etc. If a resident completed a worksheet with interpretations of the scan, if an attending signed the scan, and ultimately if the scan was transmitted to our EMR. This is what QPath looks like. You have the images obtained at bedside with the ultrasound. You have the worksheet that the resident usually completes with their interpretation of the scan, and later an attending goes into QPath and signs the scan. And once it's signed, the scan goes into our EMR and the billers can code and bill for the scan. We calculated estimated revenue by multiplying the number of each type of scan by the corresponding RVU multiplied by the Medicare conversion factor to come up with an estimated revenue generated from the scans. In the 6 months, there were about 1,300 scans, of which 900 or so met our inclusion criteria. About half of those scans had completed worksheets from the residents, and then about 350 scans were signed by an attending. Ultimately, a grand total of 328 scans, or about 34% of the original scans, were transmitted to the EMR and therefore billed for services provided. The estimated revenue from those 300 or so scans was about $7,500. The estimated potential revenue, if every single scan was signed and transmitted, would have been about $22,000. Simple subtraction, the missed potential revenue for this 6-month period alone was about $14,700 for scans that were performed but not signed and therefore not billed. In conclusion, the physician compliance for point of care ultrasound documentation was suboptimal at our institution. We were able to demonstrate that there was a fairly large amount of missed potential revenue for services that were already performed. We felt that these findings would be helpful and worthy of future investigation for our ultrasound department, given that there are a lot of costs for maintaining the machines, for educating residents and students, and that improved compliance can improve our revenue. And it also ensures that more scans go into the EMR for our consultants who are admitting our patients to see what our findings are when we're treating the patients downstairs. In the future, some things that we can look at that other studies have also looked at to improve ultrasound documentation compliance, including sharing the findings from the study so that all the staff are aware, training the staff in the software more frequently, troubleshooting any login issues, lengthening logout time so you're not signing in again and again on a busy shift, sending out email reminders, providing incentives for higher performing faculty, and streamlining the documentation process. So if there's a way to perform the scan, interpret it, sign it, and transmit it all in one place instead of going back to your computer and performing all these extra unnecessary steps, it might help with compliance as well. These are my references. And that's it. Any questions?
Hello, everyone. My name is Cristiana Balavescu, and I will be discussing the study entitled Comparison of a 2 versus 8 Zone Beeline Quantification Lung Ultrasound Protocol Using Artificial Intelligence. This research study was supported by a grant from Philips Research North America. The authors listed on the slide had their research time supported by the grant or were employees of Philips. Thoracic point-of-care ultrasound is increasingly being used by different medical specialties to aid in the evaluation and monitoring of patients with shortness of breath. Thoracic ultrasound utilizes interrogation of the pleural interface to detect B-lines, which are these hyperechoic ring-down artifacts extending from the pleural line to the far field, like this, without tapering. B-lines denote the presence of interstitial fluid, and their detection can aid in identifying causes of dyspnea. Quantification of B-lines has important implications for illness severity and prognosis. Much of the original research on B-lines and published protocols include 8 or more zones in interrogation of the lung. However, requiring a large number of zones may limit utility and utilization in clinical practice. Particularly in processes that involve the lungs diffusely, more limited interrogation may provide similar information while being more feasible for routine care. We sought to compare a 2-zone anterior superior thoracic ultrasound protocol to a full 8-zone approach utilizing ratings derived by artificial intelligence. So in terms of methods, this was a single-center prospective observational study that enrolled adult patients presenting with dyspnea or hypoxia, triaged to high acuity areas of an urban academic ED from July 2018 to May 2019. Subjects found to have any B-lines on initial lung ultrasound were included and received daily ultrasonography during their admission. Ultrasound clips of 8 lung zones, right and left anterior lateral and superior inferior, as seen in the slide, were obtained daily. A previously published deep learning algorithm was refined to rate the severity of B-lines on a scale of 0 to 4 in 0.5 increments. The original algorithm had rated them in 1 increments. Clips were rated as 0 if no B-lines were visible, 1 if there was an occasional B-line but the clip was thought to be clinically normal, 2 if the clip was abnormal but had relatively few B-lines, so on and so forth, with 4 at the most severe end of the spectrum. Half-point ratings were utilized when the rater felt that the quantity of B-lines fell somewhere in between the categories. Training clips that were used to refine the algorithm were rated by a researcher with experience in point-of-care ultrasound. A subset of 100 clips was used to calculate the agreement between the researcher and an ultrasound fellowship-trained expert, and between the algorithm and the expert. Briefly, the deep learning model was a supervised learning model. It was consisted of 3 layers of convolutional neural networks, followed by 3 layers of fully connected layers. Each convolutional layer consisted of 3 by 3 convolutions, followed by a rectified linear unit, nonlinearity activation, and subsequent max pooling. The severity class that had the highest output value by the algorithm was selected as the predicted class. AI ratings of severity obtained by averaging severity over all 8 zones were compared to ratings obtained by averaging the 2 anterior superior zones. We utilized a mixed effects model to assess how rating was related to scoring method, 2-zone versus 8-zone, in the context of follow-up time points and individual variation. To graphically display the relationship between all 2-zone and 8-zone ratings, a scatter plot of scores was also created. Linear regression was used to define the equation on the scatter plot. In terms of results, the analysis included 768 sets of 8-zone ratings from 224 unique patients. Average age was 70 years old, and 55% or 56% of the sample was male. The agreement between the AI and expert ratings was 93%. The agreement between the researcher and the expert was 91%. The mixed effects model showed that the average 8-zone score was 0.1 lower than the 2-zone score. And that was statistically significant. The linear regression and scatter plot graph showed that the 2-zone and 8-zone summaries are practically equal with a regression coefficient of 1. And that was also statistically significant. In conclusion, our results showed that a deep learning algorithm to quantify B-lines shows very similar results when using 2 zones versus 8 zones. The small difference of 0.1 was unlikely to be clinically significant, as that represents about 2.5% of the 0 to 4 scale. This study is the largest that we are aware of, comparing the use of a 2 versus 8 zone protocol. Overall, these results suggest that a 2-zone anterior superior acquisition by someone without substantial training in ultrasound interpretation could provide similar information to an 8-zone protocol interpreted by an expert. Another strong point of the study is the utilization of AI. This has potential application in allowing ancillary personnel with minimal training in ultrasound interpretation to obtain images that could be used to aid in diagnosis or monitoring of patients with shortness of breath. Thank you very much. I'm happy to take any questions.
I hope everyone is enjoying SAEM 2021, and despite the virtual format, will leave this conference more knowledgeable and a more informed emergency medicine provider. My name is Dylan War, and I will be presenting on ultrasound versus ophthalmoscopy for the evaluation of acute visual complaints in the emergency department. I have nothing to disclose, and neither do the other authors who assisted on this project. Let's take a step back and discuss ocular complaints in the emergency department. According to the 2017 National Hospital Ambulatory Medical Care Survey, visual complaints accounted for over 1% of annual emergency department visits. That's just over 1 million people nationwide annually. ED providers need to be able to assess patients with ocular complaints, particularly as ophthalmologic consultation is not immediately available in all settings, which can potentially lead to misdiagnosis and treatment delays. Direct visualization of intraocular structures is difficult or impossible when the eyelids are swollen shut after injury. In addition, fundoscopic examination is operator dependent, with training and available tools playing an important role in its clinical utility. As such, evaluation of posterior ocular abnormalities remains a challenge in the emergency department, and variable practitioner experience and comfort in performing fundoscopy complicates this picture. Prior to the introduction of point-of-care ultrasound, EP performed non-dilated ophthalmoscopic examination was considered standard of care. Use of POCUS has seen considerable growth in the last decades, and data suggests emergency practitioners can accurately diagnose conditions like retinal detachment in adult patients by using ocular POCUS, and the accuracy of ocular ultrasound for other posterior chamber abnormalities continues to be evaluated. As the uses of ocular POCUS continue to expand, it will be important to determine how EP POCUS compares to the non-dilated ophthalmoscopy exam traditionally utilized by EM physicians. As such, the objective of the study was to compare the test characteristics of EP-performed ophthalmoscopy with ocular POCUS using formal ophthalmologist evaluation as the gold standard. We evaluated patients who had acute ocular pathology, which we defined as those patients who were presenting with a loss or change in vision. These are the most common conditions that we encountered during our study. This was a single-center, prospective observational study of a convenient sample of adult patients who presented to an urban university hospital. Patients presenting with acute visual complaints were eligible to be enrolled. Each patient had a non-dilated fundoscopic exam performed by a PGY1-3 emergency medicine resident. This was then followed by an ocular POCUS performed by a separate PGY1-3 emergency medicine resident. This ultrasonographer was blinded to the chief complaint. And 3, this was ultimately followed by an ophthalmology evaluation within 24 hours. The primary outcome was the sensitivity and specificity of POCUS and of EP-performed ophthalmoscopy at identifying ocular pathology against formal evaluation by a board-certified ophthalmologist as a reference standard. Using a power analysis of 80%, our sample size calculation of 40 patients was based on previous data demonstrating a 50% difference in sensitivities between ocular POCUS and EP-performed ophthalmoscopy for diagnosing acute ocular pathology. Data are presented as proportions with 95% confidence intervals. Statistical analysis included the Fisher exact test. 226 patients were enrolled, 104 of whom had a formal evaluation by a board-certified ophthalmologist. 87 patients were diagnosed with ocular pathology, yielding a prevalence of 83.65%. In terms of our primary outcome, the test characteristics, for ocular POCUS, we found a sensitivity of 87.21%, a specificity of 100%, and an accuracy of 95.08% for identifying acute ocular pathology. In terms of the EP-performed ophthalmoscopy, we found a sensitivity of 16.49%, a specificity of 100%, and an accuracy of 67.85%. As with all studies, our project has its limitations. Our study was performed in a single center, one that is an urban academic center that serves a predominantly minority population. This may limit applicability outside of this clinical context. In addition, our small sample size of 104 patients that completed all 3 steps of the evaluation, which includes the EP ophthalmoscopy, the ocular ultrasound, and the ophthalmology evaluation, may limit the strength of our study. Our program also has a very robust ultrasound division that does ocular ultrasound routinely. Not all emergency departments have similar access to the tools and training, and this may limit applicability to all emergency departments. And lastly, although our ultrasound exam was blinded, the emergency physician, fundoscopic exam, and the ophthalmology evaluation were not blinded to the patient's chief complaint. In conclusion, based on the results of our study, point-of-care ocular ultrasound was more sensitive and accurate than EP-performed ophthalmoscopic examination for the diagnosis of acute ocular pathology in the emergency department. I will be happy to answer any questions you all may have as we move into the Q&A session.
Hi, my name is Judith Oriental Pierre. I am a third-year resident from the University of Connecticut Emergency Medicine Residency Program. My presentation is on the ability of pre-hospital providers to identify findings on extended focus assessment with sonography for trauma examination after a focused educational session. I have no conflict of interest to disclose. The use of point-of-care ultrasound often makes diagnosing medical problems and performing procedures faster, safer, and more cost-effective. Over the years, the interest of point-of-care ultrasound continues to grow, mainly because of how it can be integrated in a physician decision-making process and is a growing tool in the pre-hospital settings. Pre-hospital point-of-care ultrasound has many applications. It is a tool for medical and trauma resuscitation. It can be used to gauge the efficacy of chest compression. Pre-hospital point-of-care ultrasound may expedite pre-hospital intervention of the identified abnormality and prevent unnecessary intervention. Therefore, ultrasound in the pre-hospital setting is an important tool to assist in detecting or rule out potential harmful conditions, which may reduce morbidity and mortality and in turn improve patient care. Our goal in this study was to determine the baseline knowledge of pre-hospital providers and recognizing emergent pathologies found on an EFAS exam. And secondarily, to evaluate the effectiveness of formal ultrasound lecture with hands-on point-of-care ultrasound training. And to see if we can improve recognition of emergent pathologies that can be identified in the EFAS exam, particularly intra-abdominal free fluid, interthoracic free fluid, pericardial effusion, and pneumothorax. Our study was a prospective study of voluntary pre-hospital providers who attended an education symposium for pre-hospital providers. A total of 42 attendees participated in the study. 23 were EMTs, 17 were paramedics, 1 was a paramedic student, One attending chose not to identify their role. Each attendee were giving a pre-test that consisted of 10 questions. Question focused on pathologies that can be found during a EFAS exam. Each attending participated in a 45-minute focused ultrasound lecture, followed by a 30-minute hands-on clinical session. After the hands-on clinical session, attendees were given 10 questions. The pre and post questions were identical. Both the pre and post tests were scored and the mean were compared. Of note, each correct score was worth 1 point and no point was deducted for an incorrect answer. Our overall mean pre-test score was 2.59 and the overall mean post-test score was 4.48. We did a statistical analysis of our data using a pair t-test showing that there was statistically significant difference between the pre-test and the post-test score with the p-value less than 0.01. In the subgroup analysis, attendees were most successful in identifying pericardial effusion, free peritoneal fluid in the right abdomen, and pneumothorax, with a mean post-test score of 7.97, 5.23, 5.23 respectively. However, attendees were least successful in identifying interthoracic free fluid with a mean post-test score of 0.44. This is a chart that represents the correct scores of participants of the pre-test versus the post-test. The blue represent the pre-test compared to the post-test in red. Roughly, there was improvement in the scores. This is a still image of the clip used to represent a pericardial effusion. This is a still image used to represent free peritoneal fluid. This is a still image of the clip used as an example of a lung point. This is a still image of the clip used to represent interthoracic free fluid. In conclusion, our study showed that education of pre-hospital providers can improve their ability to identify emergent pathologies via point-of-care ultrasound. However, although a significant improvement was noted in our attendees, the majority of findings were still missed in our post-intervention tests. This suggests that the pre-hospital providers are capable of learning point-of-care ultrasound, but they would benefit more from a longitudinal educational curriculum as opposed to a single-day training session. Further research is needed to determine the ideal means of delivering a point-of-care education curriculum to pre-hospital providers. Thank you.
Hey everyone, my name is Russ Richardson. I'm an emergency ultrasound fellow at Grand Strand Medical Center in Myrtle Beach, South Carolina. I really appreciate the opportunity to present a project we've been working on titled Drowning Rule Out with Novices in Ultrasound, or the DROWN Study. Before we start, I'd like to recognize the study's co-authors, Drs. Wilson, Dr. Pope, and Dr. Arnold. I do not have any disclosures. Imagine for a moment you're on shift, and your next patient is a child who was brought in by EMS. His parents are quite upset and tell you that they were all playing in the ocean or the pool or whatever body of water is in your area when their child fell from his float and went underwater for approximately 1 minute before they were able to get to him. They say he was a little blue around the lips at first and coughed up a lot of water, but since has been acting pretty normally. He is slightly tachypnic for his age with mild fine crackles in the lung bases, but with an otherwise benign exam. So you start your workup with a chest x-ray that is essentially normal. But given his increased respiratory rate and bibasilar crackles, you wonder if the chest x-ray is telling the whole story. What if you did a bedside ultrasound on that same patient and it looked like this? You can clearly see multiple pathologic B lines throughout this lung field. In this clinical context, this is highly concerning for pulmonary edema. Now at this point, you might be wondering, well, how bad is this problem? In 2019, drowning was the second overall leading cause of death in children ages 1 through 4 and the third cause of death in kids 5 through 9. It was also in the top 10 causes of death in patients aged 10 through 24. The CDC also estimates that for every 1 drowning death, another 5 people are seen in the emergency department for non-fatal drownings. When patients present to the emergency department after a submersion event, it can be difficult to assess the severity of their injury. These patients often present a challenge to the emergency department provider with regards to disposition. Abnormal results tend to make the disposition easier. We admit anyone who we can't send home. Other times, we might not be seeing the entire picture. Is there a better screening tool for these patients? We think so. That led us to the hypothesis that point-of-care ultrasound can identify interstitial edema in patients presenting after non-fatal drownings. For our IRB-approved study, we included a prospective convenience sample of patients over a period of 17 months who presented after a submersion event of any type and received a chest radiograph as part of their care. The only exclusion criteria were patients who presented in cardiac arrest but ROSC was not achieved and anyone who declined to participate in the study. This was conducted at a single academic emergency department in Myrtle Beach, South Carolina, with an annual census of approximately 125,000. Ultrasounds were performed by emergency medicine residents who were not involved in the patient's care. They had training in the Blue Protocol, and they provided an initial novice interpretation and were blinded to chest x-ray results. 3 or more B lines present in any lung field was considered pathologic. The scans were stored in QPath and later reviewed by 4 blinded expert reviewers consisting of emergency medicine attendings and ultrasound fellows. We compared the bedside ultrasound interpretation to the chest x-ray results to obtain our statistical data. Patients were contacted 2 weeks later to evaluate for any complications following discharge from either the emergency department or the hospital for those who were admitted. For our results, we have enrolled a total of 59 patients with a median age of 6 years old. There were 21 adults with a median age of 49, 16 were males and 5 were females. For our pediatric population, we have enrolled 38 children with a median age of 3.5. Like our adult population, most were male with a total of 23, and there were 15 females. Some of the more pertinent characteristics that we looked at were seconds underwater. The adults had a longer duration of submersion when compared to children at 120 seconds versus 30 seconds for the children. The rate of bystander CPR was similar in both groups at 33% for adults and 26% for the pediatric group. The admission rate for adults was 76% versus 53% for the pediatric population. 31% of adults required intubation versus 5% for the pediatrics. And of those admitted, 94% of adults survived to discharge or transfer, and 95% of children survived to discharge. So how did ultrasound compare to x-ray? Overall, 24 patients had evidence of pulmonary edema on chest x-ray. Of these, 20 had a bedside ultrasound positive for pathologic B lines according to the novice interpretation. Compared to chest x-ray, ultrasound resulted in a 83.3% sensitivity and a 65% specificity in detecting pathologic B lines consistent with pulmonary edema in all non-fatal drownings. Interestingly, there were 12 out of 35 cases where the patient had a negative chest x-ray but a positive lung ultrasound, 10 of which required admission for further care. This suggests that ultrasound may detect significant pulmonary edema earlier than chest x-ray, which may be falsely reassuring with a negative result. Keep in mind that the interpretation of sensitivity and specificity in this population is biased, as we are using chest x-ray as our gold standard, which, as we know, is imperfect at identifying pulmonary edema. Ultrasound also appears to have performed well in patients who were ultimately discharged from the emergency department. The novice's ultrasound was pathologic in 2 out of the 3 positive chest x-rays and negative in 18 out of the 20 patients with negative chest x-rays. This resulted in a sensitivity of 66.7% and a specificity of 90%. With regards to novice performance in this category, only 1 patient was identified on expert review where the ultrasound trainee missed pulmonary edema on ultrasound who was discharged with mild perihilar edema on chest x-ray. However, this patient was doing well at follow-up without any adverse events. In closing, like other studies that have shown lung ultrasound useful in detecting pulmonary edema, we also found lung ultrasound to be useful for determining the presence of pulmonary edema in patients coming in after submersion events. It's so easy, even a novice can do it. Thanks everyone. I really appreciate the opportunity to present today.
Hello, I'm Michael Zwank, and thank you for stopping by and listening to this abstract entitled Differences in Point-of-Care Ultrasound Use Between Academic and Community Hospitals. This was a little project that I put together on my own. The background for this is that I'm the emergency ultrasound director at a tertiary care hospital. I work here and at a community hospital. And I've noticed that my ultrasound use is different between these two settings. What I wanted to figure out, is this just me, or was there differences among my colleagues as well? The objective was to determine, is there a difference in use of point-of-care ultrasound applications between academic and community hospitals? The methods, basically, I work at Health Partners, which is a healthcare delivery system that includes a academic tertiary care hospital and 5 community hospitals. All point-of-care ultrasounds are ordered through Epic, and so it's very easy to track these. In this study, I included all ultrasounds performed by faculty who work at the academic hospital and at least one community hospital. I included only those faculty that had performed at least 5 ultrasounds at each setting. This was to eliminate some of the faculty that would perform an ultrasound here and there, but not consistently. There were 31 attendings that were included in the analysis. They performed a total of 3,426 ultrasounds, including about 2,500 at the academic hospital and about 900 in the community hospitals. The ordering rate you can see here was pretty similar between the two, around 2 to 3%. The median number performed by the physicians was 47 at the academic hospital and 25 at the community hospitals. And you can see the pretty dramatic range here between providers. There were certainly anticipated differences between the groups, which included fast ultrasounds were performed much more commonly at the academic hospital, it being a trauma center. And there was a big difference also in educational ultrasounds, which are also ordered through Epic at our hospitals. You see 8% of educational ultrasounds ordered at the academic hospital versus less than 1% in the community setting. Other differences that were noted, there was a significant difference between soft tissue ultrasound ordering, gallbladder, and renal. In all cases, it was about twice as commonly used in the community setting than in the academic setting. There was a small difference in cardiac ultrasounds. All other exam types showed a less than 2% difference. This included OB, bladder, ocular, chest, OB, aorta, DVT, and procedures, among others. Conclusions. Basically, there were several important applications that were used differently, including, as mentioned before, soft tissue, gallbladder, and renal. The reasons for this could be related to radiology performed ultrasound availability, which varies quite a bit depending on time of day and which specific community hospital that a person is working at. Differences could also be related to patient characteristics, patient acuity, or a myriad of other factors. I think awareness of these differences could be valuables for attendings and residents alike. Specifically, attendings should make sure that they are teaching these adequately to the residents while they're working at the academic hospital, and residents should be aware that these differences exist and that they should maybe be paying extra attention to those applications that are performed more commonly out in the community setting. The limitation of this, obviously this was a single healthcare system, and as such might not be generalizable to other healthcare systems and settings, other community hospitals. All of our community hospitals are within an hour or so of the tertiary care hospital, and while some are in a relatively rural setting, they are still within reach of the tertiary hospital. So that certainly could be affecting how ultrasound is used in these settings. In any case, thank you for stopping by and listening to this presentation today.
Hi, my name is Samuel Neesman. I'm a third-year EM resident at University of Texas San Antonio. I want to talk to you about our 8-point lung ultrasound in COVID-19 patients. We have no financial disclosures. So over the past year, there's been some interesting studies in COVID and ultrasound. It's been found to be a good prognostic indicator. It's comparable to chest x-ray and CT. It's been useful in following the progression of disease getting better, getting worse, and sometimes even more sensitive than chest x-ray. We looked at 118 patients at our home institution, University Hospital, San Antonio. We looked at any adult patient considered a PUI that came through the emergency department. And all these studies were done in the emergency department, not later on in the course of the patient's disease. We used the phased array probe in the cephalic caudal orientation with the indicator pointed towards the patient's head. We looked at 4 fields on the left side and 4 fields on the right side for a total of 8. 1, 2, 3, 4. First one was a midclavicular line, looking at the anterior lung field. Move to the anterior axillary line, look at the anterior lateral lung field. Move to the mid-axillary line, looking at the lateral lung field. And then the mid-scapular line, looking at the posterior lung field. So 8-point lung ultrasound, 4 points on each side. Just to review how to do this, you want a nice perpendicular orientation of the probe to the pleural line. So you see here that one with the big check mark on the left is a nice perpendicular orientation of where the pleural line sits and where your probe's going in. The other ones have kind of a diagonal orientation of the pleural line. When you have that, you're going to miss some B lines, you're going to miss some other abnormalities that we're going to look for. So you want to make sure whenever you're doing these ultrasounds for any patient, you want to have that correct orientation to maximize the sensitivity of your findings. First thing we looked for were B lines. These are these vertical lines shining through, similar to what you see in pulmonary edema. You want to be at least 15 centimeters deep. We looked for 1, 2, 3 of these, or a big curtain. You can see a curtain kind of starting to form, or a confluence of B lines on the right side of that screen. The second thing we look for were pleural abnormalities, like the shred sign seen here, where there's nice, clean pleural line on kind of the left half of that. Then it gets cut and it gets jagged and a little bit deeply displaced. That's called a pleural abnormality or a shred sign. Third thing we look for is subpleural consolidations, these hyperechoic findings in the deep to the pleural line, kind of the pulmonary parenchyma. We use them to create this score. So this is per lung field. If the lung field had no abnormalities, it's a 0. If the field had 1 to 2 B lines, that's a 1. 3 B lines or more, or a confluence like a curtain of B lines, that field got a 2. If it had pleural abnormalities, like that shred sign, that field got a 3. If it had any subpleural consolidations, that field got a 4. You added up the scores of all the fields in all 8, and that gave the patient their lung score total. So here is kind of assessment of severity and how the lung scores fared with those. So for discharged patients, they averaged 5.18 with a mean score of 4, and see most of the patients are grouped over on the left side towards those lower lung scores. Move to patients that were admitted to the floor. Scores are kind of all over the place, but they've moved up. The average moved from 5.18 to 9.82, and the median score went up to 10. We move to patients that are admitted to the ICU. The grouping kind of shifts further over to the right. The mean moves up a little bit to 10.83. We move to patients that had death in hospital. Mean moves up even further to 13.14 with a median of 16. And you can see the grouping shifted further over to the right. And that one patient way over on the left with a score of 3 was terminally extubated secondary to metastatic lung cancer, not actually to complications from COVID. We assess severity by the amount of supplementary oxygen given. We look at those that received no oxygen, and their scores are similar to those that were discharged. The average of 5.51 was their lung score, and the median was 5. We moved to patients that needed oxygen, but not intubation. So this is nasal cannula, CPAP, BiPAP, high-flow nasal cannula. They had kind of scores all over the place, but shifted over to the right with an average of 11.44 and a median of 12. Patients that were intubated, there's less of them, but they're shifted over to the right again with a mean score of 12.11, median of 12. Now, when we look at this little subgroup here of patients that were under the age of 65 and a BMI less than 35, we find that there's only one patient here that was admitted with a score less than 5. And that one patient was admitted for methamphetamine or rhabdomyolysis secondary to methamphetamine use. So no patient under 65 with a BMI of less than 35 was actually admitted for COVID when they had a score of less than 5. So what we found was there's a clear trend of that mean total lung score increasing with severity of illness, especially when you look between the discharged patients and admitted, and the patients that were admitted and the patients that died. There's a kind of interesting finding that score of less than 5 in those patients under 65, BMI of under 35, they could be safe for discharge. Unfortunately, 40% of the patients that we discharged were lost to follow-up. However, of the ones we could follow up with, only 5 of them did seek a doctor after they were discharged that were in that group. And only 1 of them was there not for a previously scheduled clinic appointment, but just for new symptoms, which was nausea, and they were discharged again from the emergency department. So what's the point? Why use ultrasound? Because it's great, obviously. So it's fast, it's easily accessible, and it correlates well with disease severity seen in multiple studies, including our own. In certain populations, there could be a scoring system used to help triage these people and help get them out of the ED. And then it's useful in low resource settings, and it provides no radiation to the patient. So if you want to keep rescanning people, follow progression of disease, or if you're in a place where CT is just not easily accessible, chest x-ray is going to take forever, it can be a useful tool in helping yourself triage patients and treating them appropriately. What could be done better in the future? There could be more studies looking into this cutoff to further validate it, give it more power, and I think recording this day of illness to help assess how sick they actually worth the time that the study was done. Here are our sources. Thank you very much.
My name is Katie. I'm a PGY2 at UConn, here to present our study titled Impact of a Novel Point-of-Care Ultrasound Workflow on Ultrasound Performance, Compliance, and Potential Revenue. None of our authors have any disclosures to report. Point-of-care ultrasound is an important clinical tool for the rapid, non-invasive diagnosis of serious and life-threatening conditions in the emergency department. ACET recommends a robust POCUS workflow that includes standardized documentation and billing, transparent integration into the electronic medical record, and a quality assurance process. To date, most workflows have relied heavily on middleware such as QPath, for example, to facilitate documentation, billing, and integration into the EMR. However, some hospitals are reluctant to purchase third-party middleware and would prefer an in-house workflow that does not rely on external technical support, cloud storage, or additional expense. Our objective was to describe the design and impact of a novel POCUS workflow integrated into our EMR, Epic, on ultrasound performance, documentation compliance, and revenue potential. The study took place at an academic emergency department that sees 38,000 patients annually. We retrospectively looked at the 7 months before and after July 2019, when our novel workflow was implemented. In the old workflow, all POCUS exams were manually archived in the form of DICOM files, and interpretations with QA data were saved as PDF files. For the new workflow, the data was automatically generated in an Epic Crystal report, and we cross-referenced DICOM files for additional data. We used unpaired t-tests to compare number of ultrasound exams performed, chi-square tests to compare documentation compliance, and simple arithmetic for potential revenues generated. This is a diagram of our workflow. We start here with the provider at the Epic interface. First, the provider places the POCUS order, which links and sends information to PACS as well as to the ultrasound machines. The provider then selects the patient on the ultrasound work list, performs the exam, and when they end the exam on the machine, it automatically sends the information and images to the patient's chart in Epic. The provider then goes back to Epic to document a procedure note, which is linked to the images saved, and we'll show an example of the note in the next slide. Upon completion of the note, this generates a QA notification for the ultrasound director to attest and whether or not to drop charges. This is what a procedure note would look like. You can select one or more exam per note, and here you can see that we selected cardiac and biliary, and it will drop down a series of binary questions pertinent to those exams, followed by attestation questions, which can be completed by credentialed supervising attending or ultrasound director. The resident note and attestation statement, when added, are transparent to consultants and other providers. CPT codes for billing are linked to the individual smart forms selected. We found that there was a statistically significant increase in the average number of POCUS exams performed per month by all ED providers and by full-time attendings only after the implementation of the new workflow. This is a graphical representation of that same data broken down by months. On the left, you can see the old workflow, and on the right is a new workflow. The blue represents all providers, and the orange represents attendings only, without the help of a resident. As you can see, the dotted lines representing the average number of exams performed by both groups increase with the new workflow. We measured areas of non-compliance for both workflows, as well as exams were fully compliant in documentation. Compliance was defined as the inclusion of the patient's first and last name, medical record number, name of the operator performing the ultrasound, acquisition of POCUS images, and documentation of an interpretation. There was a statistically significant increase in the number of exams that were performed in compliance after implementation of the new workflow compared to the old workflow. We took those exams that were complete by attendings only and were fully compliant and broke them down into exam types and potential revenues generated using the 2020 RVU conversion factor. You can see here that there is a large increase in potential revenue with the new workflow from 500s to 22,000s. There were several limitations with our study. This workflow was implemented at a single institution and integrated into the EPIC EMR. It is difficult to determine whether this workflow could be adapted into other institutions, especially ones that do not utilize EPIC for their EMR. Secular drift is inherent, but we tried to minimize this by analyzing the months closest to the workflow change. And finally, there was paucity of POCUS reimbursement information from our institution's billing department. In conclusion, a robust emergency department point-of-care ultrasound workflow without the purchase of third-party middleware can be seamlessly integrated into the EPIC EMR and result in an increase in POCUS examination, documentation compliance, and potential billable revenue. We would like to thank Rob Fuller for prioritizing the development of our novice POCUS workflow at our institution, and Patricia Siegel and Claudette Shaligan for their help in making it happen. Thank you for your attention.